Hello everyone, my name is Patrick Magahis. I'm a fourth year medical student at Weill Cornell and the first author on our manuscript, Outcomes of EOS Guided Liver Biopsy using 22 gauge versus 19 gauge needles via a novel hydrostatic sampling technique.
And my name is SriHari Mahadev. I'm an assistant professor of medicine and the senior author on this manuscript. We'd really like to thank the editorial board of GIE for allowing us this opportunity to speak to you further about our paper and our technique.
And so EOS guided liver biopsy has emerged as a safe, efficacious, and increasingly popular alternative to percutaneous and transjugular approaches to liver biopsy. And a large body of work has focused on optimizing its performance, with notably 2 prior randomized trials showing 19 gauge needles to be superior to 22 gauge needles in terms of length of the longest liver cores obtained, as well as aggregate specimen length, with the primary issue of 22 gauge needles being that they procure smaller cores that are inherently more prone to fragmentation during processing. And so right now, the current optimal technique is the use of wet suction, which in brief involves removal of the stylet and flushing of the needle channel with heparin prior to applying continuous suction via the syringe. And so Dr. Mahadev, I'd like to ask you, what are some limitations of the current wet suction approach?
Right, so if you think about how wet suction facilitates tissue acquisition, a syringe is basically rinsed and the needle is rinsed with fluid, and then a vacuum is applied to the back end of the needle. And so there's continuous suction to the needle tip throughout the puncture process, which means that whenever the needle is not moving forward, there is still vacuum being applied, which ends up sucking a lot of blood into the needle bore. And that results in blood contamination of the specimen and the need to actually filter out the specimen, the need to use heparin. And so we really thought about how, from first principles, we could optimize sampling with these newer core needles that are really designed to cut tissue. And so when we thought about that, we developed this technique that is based on the idea of what's happening at the tip of the needle. So if you think about what's happening at the tip of the needle, when you're advancing the needle through the liver parenchyma, or for that matter, through any solid lesion that you're trying to acquire tissue from, there needs to be space in the tip of the needle to actually, for the tissue to enter as the needle is moving forward. And the ways that you can make space include applying a vacuum continuously, but as we discussed, that results in the ingress of a lot of blood and contamination of the specimen. The other ways that have been traditionally used are to slowly withdraw the stylet continuously, and that's a technique called slow pull. The disadvantage of that technique is that it's not synchronized with the advancement of the needle. And so the technician is continuously slowly withdrawing the stylet, which means that when the needle is being advanced, there's actually insufficient vacuum or potential space creation. And when the needle is being withdrawn, the technician is still withdrawing the stylet, resulting in excessive blood contamination. So the optimal technique involves basically holding the stylet motionless relative to the patient and the tissue as the needle is advanced into the target. So the way that we affected that was with this technique that we entitled the hydrostatic stylet technique, or the hydrostatic sampling technique. The first step of the technique is that the stylet is withdrawn from the core FNB needle. And then the bore of the needle is flushed with sterile saline, and that serves 2 purposes. The first purpose is to lubricate the actual channel so that there's very little friction with the stylet. And then the second function of the saline is to provide an airtight hydrostatic column of fluid between the tip of the stylet and the needle tip. The second step is that we reinsert the stylet back through the back end of the needle, but we don't insert it all the way. We leave it out about 30 centimeters, and that's so that the needle is not in the articulating portion of the endoscope, so as to reduce friction with the bore of the needle. So that's the setup of the needle, and after that, the needle is introduced after identification of the target, as in the standard EOS technique. In our case, we typically take biopsies from one or both lobes of the liver. So we would start off on the left lobe of the liver, which would be a transgastric puncture. So after identifying an appropriate target and an appropriate runway, we basically have the technician hold the stylet motionless as the operator of the endoscope advances the needle with a sharp, short thrust into the liver parenchyma. And then that is the first puncture. After that, we do 3 more actuations, which means that we draw the needle back to the liver capsule edge, but not all the way out. And then we advance again while the technician holds the stylet motionless. He lets go or she lets go again, and then we do it 2 more times for a total of 4 actuations. After this, the needle is withdrawn entirely, and the specimen is expressed directly into formalin by advancing the stylet through the bore of the needle. There's no need for rinsing the specimen, and there's very little blood that emerges because the amount of space that's been created in the bore of the needle has been exactly equal to the amount of tissue that is acquired.
To evaluate the performance of this technique, we conducted a retrospective analysis of all patients at our institution who underwent EOS-guided liver biopsy with 1 needle pass via either the novel hydrostatic sampling technique or the standard wet suction technique. Our primary outcome was tissue adequacy, defined as specimens obtaining an aggregate length greater or equal to 2 centimeters and 11 or more complete portal tracts. We also analyzed the secondary outcomes listed here. Finally, an expert GI pathologist re-reviewed all samples at the time of analysis and was blinded to both the size of the needle as well as the sampling technique used during the procedure. We first compared the 74 patients who underwent EUS-guided liver biopsy using the novel hydrostatic sampling technique, of which 30 used a 22-gauge needle and 44 employed a 19-gauge needle. We observed no statistically significant differences in terms of their baseline demographics. In terms of our outcome measures, all 74 procedures performed using the HST procured cores that were sufficient to inform a final pathologic diagnosis. In terms of our primary outcome of tissue adequacy, both groups attained an adequacy rate of 93%. Looking more granularly at aggregate specimen length, number of CPTs, and length of the longest core post-processing, we see as expected the 19-gauge group obtained longer cores. However, the differences between the 2 groups did not reach statistical significance, and notably, the measurements obtained in the 22-gauge group are well beyond the minimum standards for adequacy defined earlier. We also compared the degree of blood contamination between the 2 needle gauge groups, which was defined using a score stratified by the percentage of the slide surface that featured red blood cell contamination. Notably, the 22-gauge group had significantly lower blood contamination scores. We also compared the degree of specimen fragmentation between the 2 groups, which was defined using a score stratified by the proportion of fragmented liver cores to total liver cores, with fragmented cores defined as those measuring less than 5 millimeters in accordance with published literature. We observed no statistically significant differences in terms of fragmentation scores between the 2 groups. Finally, we also observed an over 3 times decrease in the incidence of post-procedure abdominal pain following EUS-guided liver biopsy using a 22-gauge needle compared to a 19-gauge needle. To further contextualize our data, we compared the 30 procedures performed using the 22-gauge HST approach to 52 procedures using the standard approach of a 19-gauge needle with heparinized wet suction. Notably, we found no statistically significant differences in terms of any outcome measures, with notably our primary outcome of tissue adequacy being numerically higher in the 22-gauge group, 93%, versus the 19-gauge wet suction group, 85%. Our results remain consistent in terms of significantly lower blood contamination when using the 22-gauge HST approach, and no statistically significant differences in terms of specimen fragmentation. Lastly, post-procedure abdominal pain continued to be significantly lower in the 22-gauge needle group.
Thank you, Patrick, for that great summary of our study and its findings. So to summarize, in this retrospective review, we compared the use of a new novel sampling technique for liver biopsy called hydrostatic stylet technique, And we compared the results of the use of this technique with a 22 gauge needle and a 19 gauge needle to the standard gold standard technique, which is wet suction with a 19 gauge needle. As you saw, our results demonstrate that you can achieve extremely high quality specimens with 1 pass and 4 actuations using a 22 gauge needle. We found significantly lower rates of pain after the procedure, as well as very high CPT counts. So we hope that these results and findings are interesting to you, and obviously we need to continue to study this in a prospective fashion. Thank you again for your attention, and thank you for the GIE to give us this opportunity.